I'm going to be looking first to start with, then I'll listen with my stethoscope, and then I'm going to feel. But before I jump into all of that, do you have pain anywhere in the abdomen?
No.
And have you emptied your bladder?
No.
No. You'll have to jump on
I
it.
think I'll be okay.
Because I am going to palpate you. But at any stage, if you feel like you're feeling uncomfortable, please just quickly let me know.
Okay.
Yep. The other question I had to ask you was, what was your last meal?
Probably about an hour ago.
Okay. Okay, that's good. And do you suspect you might be pregnant?
No.
That's great. So what I'm going to start with is I'm just going to start looking for starters, and then I'll start listening.
Okay.
Yep. Korean and for your step one. I get to a sortation. Yep. Just because I haven't pulled it out from the card. Now, as far as inspection is concerned, yep. So the umbilicus is in the midline. The umbilicus is inverted. With regards to lesions, I do not see any scarring anywhere on the abdomen. There are few brown spots of discoloration concentrated around the left upper quadrant, a bright red spot on the right upper quadrant. I do not see any striae. The abdominal aorta pulsation is visible. There's no signs of any peristaltic waves, and there's no signs of any intra-abdominal bleeding due to no bruising being seen. I think that's it. Moving on to auscultation, can I borrow a steth? Thanks, great. So I'm gonna avoid putting it in my ears, just putting it around my neck so you know what I'm up to. But ideally what I'm doing is listening for vowel sounds for a whole minute. I'm just starting to use any quadrant at the moment because of the fact that she's told me that she has no pain, so I can start anywhere. But if she had pain, then I would leave that quadrant for the last. For instance, if she said she had pain in the left lower quadrant, I would start with the right lower quadrant and go around in a circle, come to the left lower quadrant last. Okay? So basically I will listen to vowel sounds for a whole minute. I'm then going to use my belt to listen for abdominal aorta sounds or arterial sounds. Ideally I shouldn't hear anything. If I do hear something, it'll sound like a brute or a whooshing sound. Okay?
So how many times are you going? Are you just doing?
I'm just doing one in each quadrant.
Okay.
One spot in each quadrant. However, if I don't hear sounds, then I'll move it around in that quadrant to see if I, kind of not touch the right spot or whether I'm missing anything. Or if I hear too many sounds, then again I'm sorry. So either end of the spectrum, if I closer to the 5 or closer to the 15, I want to investigate that a little more. Yep. So that brings me to the end of auscultation. I'm now moving on to percussion. So again, because she said there's no pain, I can just use any particular quadrant. So I'm starting with right lower quadrant. So I hear timpani in all the 4 quadrants. Yep, downwards over the liver, part of the right lower costal margin. Yep, downwards over the spleen, again hard at the left costal margin. No signs of hepatomegaly or splenomegaly. I'm now jumping on to palpation. I'm going to start with light palpation and then I'll move on to deep palpation. Yep. So as far as light palpation is concerned, this is literally me doing a check before I go deeper. Yep. So what I'm feeling for is any masses or any signs of tenderness before I start pronging much deeper. Yep. So Melanie, I'm just gonna feel around your abdomen now. Let me know if you feel pain or any signs of discomfort. Do you see I'm not going very deep? I'm literally going possibly just about a centimeter. Again, following a circular motion until I come down to the umbilicus. Did that give you any sense of discomfort? It's good. I'm now going to go a bit deeper. Feel free to stop me at any stage if you feel uncomfortable.
Yeah.
Do you see how much deeper I'm going this time? Now I am jumping over her bladder area just for now as a demonstration, just because she's told me she might have a slightly full bladder. Yep. So no masses or tenderness felt. Now I'm going to jump on to specific tests for the liver, the spleen, etc., etc. Yep. So firstly, a hooking technique for the liver. My left hand under the liver, pushing it upwards, and I'm hooking with my right. If the liver was enlarged, I would be able to feel the lower border of the liver on this hooking hand. Yep. But on percussion, we've already identified that her liver sits well within the costal margin or just at the costal margin, so I don't expect to feel an enlargement. But do you get how you would ideally use this test in conjunction with percussion? Yep. So if, for instance, on percussion I felt dullness a little lower, I'd start my hooking from below the umbilicus and keep going until I find the lower border of the liver. Yep. Same with the spleen. Left hand goes under. Don't worry, just relax. Left hand goes under. Yep. So I did not feel any signs of hepatomegaly or splenomegaly on my examination. I'm now moving on to balloting of the kidneys. So on the right side, pretty easy. I ideally shouldn't feel anything. You should just feel like soft tissue because the kidneys are quite small and are squishy, soft organs. So I shouldn't feel anything, but if there was an enlargement, urine retention, or if there was tenderness, that would indicate that there is a sign of pyelonephritis. Yep. The same with the other side. Yep. So you could use either hand for this, but ideally you're trying to squish the kidneys between the hands. Yep. Did that feel quite revolting? So I know some of you are kind of wincing a little bit, going, oh my God, but it really, the client doesn't feel it doesn't look like I'm actually poking and pronging at her. I know I'm calling it pronging, but it doesn't really feel like that for a client. Yep. Now, the other test that I'm going to do, so I've done kidneys, I've done liver, I've done spleen. Yep. She's got a slightly full bladder, but if, for instance, she was telling, if for instance, she seemed like she had an UTI, then I would percuss over the bladder to see if there's urine retention in the bladder, expecting that she has emptied her bladder before she has come on to my examination bed. I shouldn't find a full bladder, but if there's urine retention, then I will ideally be able to hear a dullness on my percussion. Yep. Going on to the test for appendicitis. Now there's a couple of them. I'm firstly doing McBurney's and then I'll move on to the next. Yep. So this is a test for rebound tenderness. The McBurney's point, you've got to firstly identify it. So you look at the iliac crest, this bone, the umbilicus, draw an imaginary line between the two. 1/3 from the iliac crest or 2/3 from the umbilicus, whichever way you want to look at it, is your spot, your McBurney's point. All I'm doing is this. Actually, you've got a slight nail, so I'm going to use my knuckles instead. Did that hurt? Yep. And you're looking for pain on rebound. So when you're taking your hand away, you're looking at the client's face to see if there's, slight wince or the client is reporting tenderness. Yep. The other test is the Robson sign. Same, pretty much the same test, except it's done on the other side. So this is done in the right iliac fossa. If there was appendicitis, the client would have felt pain in the right iliac fossa when we press the left iliac fossa. Because ideally what I'm doing is I'm pulling the fascia over the inflamed appendix, and that's going to be what you would see as pain. Yep. Now the other couple of tests, I'm going to need your legs to be involved. So if I can get you to spread your legs out slightly, I'm just going to drape. So it's all good. Now the next test is called the iliopsoas test. We're using the iliopsoas muscle.
Can I ask you a question before we move to the next?
Yeah.
If you suspect a ruptured appendicitis,
Yes.
do you still perform?
Good question. Now, if you suspect that there is a significant chance of being appendicitis, or you think there might be a ruptured appendix or an appendix which is about to rupture, would you perform the examination for appendicitis? I would say yes.
Still.
Hear me out. Hear me out. I would say yes. Before you decide to send them to hospital, if you do the examination yourself, you know what you're sending them for. Yep. Now, the key thing here is I won't do a McBurney's point. That's the reason why I'm showing you 4 tests or 5 tests, not one, because at this particular instance, I will choose not to examine the McBurney's. Yep. I could do left iliac fossa, or I could do the iliopsoas, or the obturator, or the Blumberg's, so that I am eliciting the same test, but I'm not actually pressing over what might be an inflamed appendix. Yeah. Now I can see from your faces and the non-verbal feedback that I'm getting is I'm not very comfortable doing it. If I think I have a client with appendicitis, I'm just going to send them away. Well, like I mentioned, that is up to you. As a tutor, I would set an expectation. What you do in clinical practice is obviously what stands with your beliefs in your practice. Yeah, but here within the classroom environment, my job is to teach you how to do it. So I'm teaching you how to do it, and I'm telling you when or when you would do the alternative test.
Is it rebound pain will be always present with appendicitis?
Yes.
Yes. Okay.
Yes. So that's one of the key things to sort of look at. Pain on pressing would not be appendicitis. It's the rebound pain that will help you identify that it's appendicitis.
Yeah. So when you take
The hand away, that's when the pain comes. Yes, Danya?
What happens if they got like their menstrual cycle or something?
Yep. What if they've got their menstrual cycle? Do we expect to find soreness and tenderness around the abdomen?
yeah.
Or no rebound because they're bloated or whatever?
No, if the appendix is inflamed, you'd still get the rebound tenderness. And that's the reason why I'm saying you've got to sort of look at it. So with abdominal sort of soreness from the menstrual cycle, the pain will ideally not increase on examination. That's one way. Second of all, there'll be a tenderness present even before my examination. Thirdly, when I press down is when the client's pain is going to increase, not when I've taken my hands away. Yeah, so that's how you would differentiate whether it's appendicitis or it's something to do with the ovaries, for instance, because they lie in a similar area. Yeah, if there's an ovarian cyst, it could also present with pain, the same sort of fever, symptoms like nausea and vomiting, etc., or colicky pain that you expect to also find with appendicitis. But the way you will differentiate is this rebound tenderness test. Yep.
I had the rebound pain at some stage, and they shot me with adrenaline and sent me off to the hospital. But it wasn't until they got me into surgery that they realized it wasn't appendicitis. It was an abscess on my appendix, but I had
Ah.
all the same.
Yeah, yeah.
That's the only test they did.
Yeah.
Before
Yeah.
putting me to surgery.
Yeah, but that's the thing. You won't be able to tell the difference on a physical examination because it is the appendix.
They should have done
Still.
an ultrasound.
Anything.
Yeah.
But I guess because it's
Yeah.
like an emergency surgery, they
Yeah.
just.
I
They just took mine out.
pardon?
They just took it out. I just went in and then came back out and it's gone.
Yeah, well, I actually had it when I was pregnant, both times, but the second time, definitely. And I had a scan, and they said sometimes you don't see an inflamed appendix even when you scan, but you've still got appendicitis. But mine was definitely inflamed. So yeah, they wanted to take mine out, but I was pregnant. And I was like, well, what about the baby? Oh yeah, it could be deformed, or you can miscarry and all that. And I said, well, guess what? No, I haven't it. So yeah, I still have appendix.
Anyway, traditionally, it used to be common practice to remove the appendix, but in the last 10 years, we have learned the value a lot
Yeah.
more of the appendix. We used to, when I learned in 2003, my anatomy textbook said the appendix was a vestigial organ that has still since been removed from anatomy and physiology textbooks. Because we now know that it's not a vestigial organ. We don't fully know everything about the appendix, but we now know that it has a bigger role to play than being a vestigial organ. Yep. All right. So moving on to the other tests that you would do. So I've demonstrated to you McBurney's and Robson. I'm moving on to iliopsoas. So Melanie, what I'm going to do is press on. So I'm pressing, so this is her knee, pressing on the thigh just above the knee. And if I can get you to lift your leg, lift your right leg. Yep. So a client with appendicitis will feel a wincing pain the moment she tries to do this, because again, that is pulling over the same fascia. Yep. And the fourth test is the obturator test. Now this one gets a bit trickier. I'm going to give you a few more instructions. So what I'm going to do is I'm going to fold your foot, and I'm going to move it up to your left knee.
Yep.
Yep. Does that feel comfortable?
Yep.
Yep. And then I'm pressing down so pressing down on the side here. Again, pull the obturator muscle, which will ideally pull over the fascia. Yep. So we can get you back in position. Thank you. Yep. So ideally, a good way to drape for this particular test, especially if you've got a female client with a skirt, etc., etc., what you could do. And I tried doing that, but this sheet is not long enough or wide enough. But if you don't mind me folding it up, yep. So ideally what you would do is put it in between the legs, put the sheet in between the legs, and then as you turn the client's leg up, you fold this under, and you're doing this.
Why would you do that one instead of the one before the
Oh, so it's just whichever
that
one
looks
you
a lot more complicated.
Yeah.
than just
So
lifting the finger.
so that's what I'm saying. It's just a couple of tests that you have.
Yeah.
For instance, you do the iliopsoas. Client says, "Oh, I just felt a niggle." You're like, "Oh, okay, I'll do another test to see before I confirm that this is appendicitis." So that's where these extra tests come from. Yep. And the last is the Blumberg test. Now, this is a test that is commonly used for peritonitis, where you suspect the appendix is already ruptured and caused peritonitis. Yep. So this is rebound tenderness anywhere in the abdomen, but ideally I'll avoid the area around the appendix just to avoid making it even worse. Yep. But rebound tenderness anywhere in the abdomen would be a sign for peritonitis. So this is a test you can use independent of appendicitis if you suspect your client has peritonitis. Say from an acute pancreatitis or something like that, where you suspect there might be peritonitis that is set in, then you can do the Blumbergs. Yep. Everybody with me? Right? One last test that I'm going over is the Murphy's, which is the test done for cholecystitis or cholelithiasis. Yep. So where I do that is I find the xiphoid process, or the lower part of the sternum, 2 centimeters to the right. Actually, no, 2 inches to the right. These numbers, right? So 2 inches to the right. Yep. I'm going to press in while the client takes a deep breath. Because ideally, when she's taking a deep breath, diaphragm falling down, bringing the gallbladder further to the anterior side of the abdomen, and I'm pressing over what should be the area where the gallbladder appears. The client will either stop taking the breath, because I'm going to ask her to take a breath while she does this. She'll either stop taking the breath because she's in pain, or she'll wince in pain. Yep. So you're watching the client's face, because many clients might not express that they're feeling the pain. They might tell you after that they felt the pain. Yep. So Melanie, if I can get you to take a deep breath. Did that hurt? And did you see when I pressed? Let me repeat myself. So Melanie, if you can take a deep breath. So I waited till she's at least halfway through the breath so that the diaphragm has actually fallen low enough to push the gallbladder away. Yep. So that way is some of the special tests that you will do. Now just going over shift in dullness. So if, for instance, I see that the the signs of ascites, then what I'm doing is percussion. And of course here I'm drilling tympani all along. But if she had ascites, when I come to the side, you will start to hear dullness because there's a lot of fluid accumulation over here when she is lying down. Yep. So can I get you to turn to your left? Yep. And now I wait 30 seconds after she has turned, so to allow for the fluid to drop. And now again, I percuss. Obviously here you won't hear the difference because she doesn't have ascites, but if she did, there would be a tympani on the side now and a dullness in this region. Yep. Thank you, Melanie. You can fall back down. Yeah, so that's the shifting dullness test. Another test is the fluid wave test. So, Corinne, if I can grab you in on this one, help me out. If I can have you place your hands in the middle. Yep. Ideally, what I'm doing is tapping from one side. Can you feel anything? Is what I'm looking for. Yep. So, if there's fluid, you tap from this side. Ideally, there'll be fluid moving. The wave will hit her hand in the middle. Yep, a tsunami, yes. Yep, it'll feel like a little tsunami on Corinne's hand. And the same with the other side. You tap and then it'll hit in the middle. Now if you don't have somebody else with you, the way you would do this test, hold your hand here, tap, the fluid wave should come. It's just the reason why I'm using another person here in the midline is because of the fact that sometimes there's not enough fluid for the wave to actually travel all along.
Why can't you use your hand in the midline? Yeah.
Because then I'm doing this. And I'm not able to tap well enough. So when I've spread myself out, I'm not putting my weight on her. Because otherwise I'll be here in the midline, putting my weight in the middle, and then having to tap. It does get a bit it's not the perfect way to do the examination, but you could do it. Yep. You could also just tap and see whether there's a wave passing.
How do you know it's not fat?
Yeah.
How do you know it's not fat?
I'll have a wave.
Yeah.
No.
I think I should have drawn a little smiley face.
Hi. So when you tap, now if you see here, there's a slight movement. Yep, that's basically coming from, I wouldn't say abdominal fat, it's just the tissue being a bit lax. Yep. Now the wave here, if you look, it's not actually a wave, it's just the movement of the whole tissue happening in one go. But if there was fluid, you literally see those ripples and waves.
Wow.
Yep.
Okay.
How common is that?
Not very common. You can cover up.
So this is ascites.
That's just ascites.
Ascites.
That's for ascites.